Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use recommended personal protective equipment, such as gloves. To help improve your assessment skills, the American Heart Association training series includes videos of actual children with medical problems. Of course, at no time was medical care delayed for the purpose of obtaining this video. All children received timely and appropriate medical care, and parents provided consent before recording.
Intraosseous or IO access can serve as a rapid, safe, and reliable route for the administration of drugs and fluids when peripheral venous access cannot be rapidly achieved. The IO route provides access to a non-collapsible venous plexus, which is especially useful during resuscitation. This serves as an acceptable alternative to the IV route for any PALS medication that can be given by the IV route, including vasoactive drugs. IO access also provides an alternative route for the administration of crystalloids and colloids. Many sites are appropriate for IO infusion. See your device-specific instructions for a list of approved sites. For children, the most common site is the proximal tibia. In order to access this site, position the leg with slight external rotation. Identify the tibial tuberosity just below the knee joint. The insertion site is the flat part of the tibia about 1 finger width, or 1 to 3 centimeters, below and medial to this bony prominence, so as to avoid injuring the growth plate. Stabilize the leg on a firm surface to facilitate needle insertion. Do not place your hand behind the leg. The stylet should remain in place during insertion to prevent the needle from becoming clogged with bone or tissue. Insert the needle so that it is perpendicular to the tibia. There will be a sudden lack of resistance when the needle is placed correctly, and the needle should stand easily without support. Remove the stylet and attach an empty syringe to confirm appropriate placement. Aspiration of the syringe may reveal pink-tinged fluid or blood in the hub of the needle. But if no fluid returns, it does not necessarily mean that the IO needle is incorrectly placed. Attach a saline-filled syringe and infuse a small volume while observing for swelling at the insertion site, and posteriorly in case the needle has penetrated the other side of the bone. Fluid should easily infuse with saline injection from the syringe. The distal tibia just above the medial malleolus, the anterior aspect of the distal femur just above the knee, and the anterior superior iliac spine are other sites that can be used for IO access. After the IO needle is properly inserted into the bone and appropriately secured, drugs and fluids flow through the bone marrow cavity into the circulation, though depending on location, they may first pass through peripheral circulation. As is routine practice when providing most IV drugs, all IO medications are followed with a flush up to 10 milliliters, depending upon the size of the child. Keep in mind that even after successful insertion of the catheter into the bone marrow, there is often resistance to infusion, which a provider may mistakenly interpret as incorrect placement. Bolus administration or the use of an infusion pump may be useful in overcoming the resistance. Healthcare providers should keep in mind that certain contraindications exist. Contraindications to IO access include fractures and crush injuries near the access site, conditions with fragile bones, such as osteogenesis imperfecta, and previous attempts to establish access in the same bone. If infection is present in the overlying tissues, IO cannulation should be avoided. After IO cannulation, providers should check the site frequently for signs of swelling and needle displacement. Remember that fluids or drugs delivered via a displaced needle can cause severe complications, such as tissue necrosis or compartment syndrome. IO needles are intended for short-term use, generally less than 24 hours. Replacement with long-term vascular access is usually accomplished in an intensive care setting.